It's a big button to go back one. So it is really an honor for me to share with you today on a subject matter that is close to my heart, but is also one that I have the privilege of working with a lot of people. So I speak on behalf of my co-authors and also with a team of field staff that have worked with me for almost 15 years now, since 2012, studying some iteration of children that are HIV affected. I'm going to be speaking about the long-term cognitive mental health and quality of life outcomes, and the emphasis here is that we're really looking at these children when they're during school age and adolescent years of life, when they have some lived experience. And the other alternate title for this work, as I speak about it, is really thinking about functional survival. It's not enough that people survive, but we also desire that they will thrive. I have no conflicts of interest to declare financially, at least, and I serve as a consultant for the Michigan Alzheimer's Association, where we're basically looking at the overlap of aging with HIV and the issues that comes with that. I have educational support, but also research support from Foundation and NIH sources. I'm really proud to be a CIFER grantee, because CIFER was one of the first major people that bought into the way that I was looking at this work. So Lazarus gave us some background that is really relevant to think about children that are HIV affected. So in my work, I have usually three groups of children. There are children in the affected group are children who are perinatal, who are born to HIV-positive pregnant women and acquire the infection. You will see me use the acronym CPHIV just to make the slides look easy. Think of them as positive controls, unfortunately. And what this means is that we expect some disadvantage compared to children who are unexposed, unaffected, as a way to basically understand their relative functioning. The group that is really also highly HIV affected, the fastest growing demographic of people living with affected by HIV are children that are HIV exposed but uninfected. And this population is rising dramatically. It is a population we're seeing because some things that we have been doing have worked. The combination of expanded access to ART, allowing evidence to guide global and public health policy nationally and locally, and the great work that has been done by many in this room to scale up and prevent maternal to child transmission. And in many cases now, we're talking about the elimination of maternal to child transmission in HIV. Really impactful work. What that results in numerically is that if you compare to 2002, by 2022, you basically are seeing that the incidence of new infections in children has dropped by an astonishing almost 80%. That is concrete evidence that treatment is prevention, and it's allowing us to ask the questions about what about the children that are HIV exposed but do not live with HIV themselves? Because pregnant women can now live the dreams of actually being healthy enough to have their own children and fulfill the aspiration that many of us desire as adults, we now have a population of about 14.8 million children globally that are HIV exposed but uninfected. If you think about the rise in population, that's 250% rise between 2000 and 2018. So huge numbers that they're without infection, and it's easy to think of them as completely okay. So when you think about where do they live, about 50% of that population lives in 5 countries: South Africa, Uganda, Mozambique, Tanzania, and Nigeria. But another way to think about the importance of this population is to also think about their percentage as a function of the overall number of children in a country, right? So there's about 5 countries, most of them in the Southern Africa region, including Namibia, where children exposed but uninfected account for more than 15% of the general population of children. So this is a very rapidly growing number that we expect to see grow even further in the years to come. So to think about how do these children, we don't understand this population very well, and that's the essence of our work. One of the things that we see is that early on, and where we do have the information, is usually within the first 2 years of life, so infancy to about 24 months of life. We have evidence that when you look at on the bar graph, if you look at in terms of mortality, you see evidence that comes from a very early study, 2007, where you basically see that the rate of death per 100,000 is about more than 2 times higher for children that are HIV exposed compared to those who are controls. And then in another paper, I think this is 2016, I don't have my glasses, so I'm guessing on that. But the children who are HIV, in terms of the morbidity, overall infectious morbidity is much higher in this population, significantly higher. But a lot of that difference is driven by diarrheal morbidity, so that in very early life you have a lot of these soft morbidities that really affect developmental trajectory, impacting HIV-exposed children more than others. Moving on to cognitive development, we also see evidence early on that these children are developmentally disadvantaged, whether it is looking at their overall cognitive sorry, I'm just trying to see my slides a little bit better. So if you look at, so some of the risk factors that actually increase the risk for developmental outcomes, you look at preterm birth or low birth weight. You basically see that the odds of that is higher in children that are exposed uninfected. Similarly, you see that we see higher prevalence of stunting in HIV-exposed uninfected children. And also, importantly, and I have an asterisk there because this is a little bit of a subgroup effect where it's stronger in one subpopulation, specifically males in this one study. But we see emergent evidence of cognitive disadvantage in this group for HIV-affected children, exposed children, having worse cognition. So, and then a study by Roland Jones and others has begun to explore the mechanisms for this. And one of the key things that they found when they look at the immunologic profile of these children is that there's net higher inflammation and immune activation in this population compared to control. So some evidence biologically and mechanistically that these children are different. And so why is that? And one of the things that I don't want anyone to leave here thinking is that, that our work is trying to say that pregnant women should not get ART. That's not the point of this. But I do want us to recognize that, that for the effectiveness of ART to do what it has done, it requires that these very potent drugs will cross the placental barrier, they would rise to therapeutically high levels and to protect the fetus. And what this means for the long term is something that we need to understand. We're always thinking about care as risk benefits. Clearly, the direction of risk benefit favors treatment because HIV infection is not what we would like. What we do see is that partly because of that exposure, almost every study you see that looks at these populations will see that there's higher rates of low birth weight. If you look at mitochondrial toxicity and markers of neurotoxicity, you would see that they're higher in HIV exposed, ART-exposed infants. So, and that leads me to what I'm going to share today, to try to understand, just descriptively, how do these children compare to one another over time, especially past school age and adolescent years of life. We enroll our samples at 6 years of age, between 6 to 18, and the number of children would vary across studies, but I have as much as 1,050 children, and I co-enroll their adult caregivers, follow them forward in time, and we repeat the assessment of our outcomes every 6 to 12 months, and for as much as 5 years, because these are very long-term studies that we've been doing. By design, we've selected these children so that we have an approximate 1-to-1-to-1 ratio in terms of the bi-perinatal HIV status. So our enrollment ranges from 2017 to 2023, so these are very, there's a period of time there where we've enrolled and analyzed them. So we define cognition using performance-based cognitive markers. These are objective measures where we give paper-pencil tests to children, and then we see how they perform and document that to basically look at how their brains is working. We also measure mental health outcomes, where these children are old enough now to self-report their own anxiety, depression, and internalized risk symptoms based on the behavioral assessment system for children. And then they also self-report their quality of life using the pediatric quality of life inventory. I'm going to speed up a little bit here, but we do this very detailed analysis, descriptive as well as regression analysis to basically adjust for confounders and estimate HIV-associated differences in those outcomes. We do cluster at the household level because a caregiver could technically have more than one child in our study, and we adjust for a range of confounders. What I do want you to pay attention to is that the results will be emphasizing the differences in function by perinatal HIV status. I show the child living with perinatal HIV as a comparison for you to see what that looks like, but then the group you want to be paying attention to, based on the title of my talk and my assignment, is really the exposed uninfected children. And the group in green would be the control kids. So the average child in this study is 12.5 years old. We have, when you look at them by age, the child living with HIV is a little bit older than the other two groups. But we have equal number of boys and girls. At baseline, you see the disparity in quality of life, really strongly so for children living with perinatally acquired HIV. You actually see some overperformance of exposed uninfected children at the beginning, and you also see that, but those levels statistically are similar to what you would see in control population. Again, we're thinking about where cognition starts, and when you measure cognition, there's several ways you can do this. You can give someone a test that is timed, and if you're really good at timed tests, what you would expect is that you will finish things quicker. Or you can give a test where someone has a number of things correct at accuracy. You would expect that higher scores would mean you're doing better. So right at the beginning, we see strong differences by HIV status in these outcomes. Specifically, when you look at time tests, which is our, I don't think I have a pointer, but the bars pointing up, that is showing you the trend we expect, that children that are living with that are affected by HIV in a graded fashion as taking more time to complete the test. And then when you look at number correct on simple digits modality or immediate recall, you see that they are at a disadvantage compared to control. And all of that is significant at baseline. And also at baseline, thinking about mental health, you see no difference in mental health outcomes, specifically depression and anxiety at baseline. But when you look at somatization or internalizing problems, you see evidence that HIV-affected children are at a disadvantage. I'm now beginning to speed up a little bit to show you some change over time. So this is, the study base here is 892 children in whom we have performance-based cognition. Average duration is about 30.2 months of follow-up. But we have them as much as 85 months or a little bit over 5 years. And then the effect measures that I'm showing you will be time averaged over all the observations we have in them. This is a forest plot, and one of the things to just orient you to this slide is that I show you differences compared to differences compared to the controls, the CHUU. And then on a forest plot, anything that crosses the dotted red line is not statistically significant. And these are now time to completion tests. So we basically are seeing that across all the tests that measure time to completion, you see that children that live with acquired HIV infection have absolute worst disadvantage. It's all positive. It's all not touching that line. When you look at the children who are HIV exposed and uninfected, you also see the same story. I don't show you the numbers of the average, but basically they're also at a disadvantage at a lower level, but statistically different from the controls. The one conclusion you can have here is that on speeded tasks, children HIV exposed uninfected are underperforming compared to controlled children. And this map directly into deficits in various brain regions that I just point there for you to get a sense. Now, this is still on cognition, but looking at the number correct and accuracy. When you look, the children that are living with HIV are easy to interpret. You see average worst performance. When you look at the exposed uninfected children, you see a mixed pattern of, basically you conclude largely no difference for the first three tests. For the fourth test, the motoric function finger tapping, you actually see an overperformance in one of them. And then for the other three tests, so you see a pattern that suggests relative disadvantage on recognition, delayed recall, that is strongest in immediate recall, which is a marker of learning. So, that suggests some challenges with in academic type settings. We should be paying attention to how these children perform. Depression indices continue to basically show that, or mental health indices, that there's a disadvantage regardless of the group of children that we're looking at in all but one of the depression markers. So no difference in the exposed or infected children based on depressive outcomes. They are at a disadvantage. When you look at quality of life, you see the absolute deficit for children living with HIV, but the exposed uninfected continue to overperform or thrive or are basically no different. So to summarize, we basically see Disadvantages in cognition, worse for the infected child. Some exist in some domains for the exposed uninfected child compared to the controls. Mental health challenges for both groups of children and quality of life challenges for the infected children only with, based on self-report. So let me conclude. We basically see that the exposed uninfected children manifest a pattern of deficit on speeded tasks of cognition. And then we see that, evidence that learning and delayed recall, and the pattern of performance in learning and delayed recalls really raise concern for achievement or maybe higher levels of achievement for these children in academic settings. I did have data for school-based stuff that I didn't show you today that basically shows that concern does bear out, at least in our data. And then we see that mental health is a challenge for both groups of children in terms of but overall well-being, as perceived by the child, is actually similar for exposed uninfected children compared to controls. So supporting their long-term developmental trajectory demands that we first understand them and then use that insight to target their intervention. I want to thank you so much for your time and thank the partners that support our work and for the many ways, but also really thank the children that really ground my sense of joy and purpose as we do this work, and trusting that we would have opportunity to keep doing it. Thank you.